One of our greatest concerns in providing dementia care is the development of secondary health complications. In other words, as the person's dementia progresses, their physical condition deteriorates. They become less active, less agile, and their body becomes more prone to health complications. These can include pneumonia, urinary tract infections, and the like. Our goal as a care provider is to help prevent secondary health complications as much as possible, to provide the greatest quality care we possibly can for our residents. During this video, you will learn about some of the common health complications in dementia, how to monitor for them, and how to properly intervene. Residents with dementia often have difficulty communicating their symptoms to us. If the urinary tract infection they're suffering from causes pain, they may not be able to clearly explain that to you. If the pneumonia beginning to develop in their lungs is causing them to feel tired, sore, and fatigued, they may not be able to express that to us in words. What often ends up happening in dementia is the person will display these symptoms in other ways. Very often we will see behavioral manifestations of these physical problems. As the pain of infection begins to overwhelm the resident, they may become agitated, irritated, and even aggressive. So anytime you see a behavioral change in your resident, particularly if it's sudden and drastic, we must always assume that there could be an underlying physical cause for that behavior. Work with your supervisors and the resident's physician to rule out underlying physical complications in addition to other behavioral interventions. Your aggressive attention to detail can help to ensure a greater quality of life for your resident. In the United States, as many as 10 million visits are made to physicians each year to seek treatment for urinary tract infections. In most cases, these infections are easy to cure if the person follows the physician's instructions. The urinary tract makes and stores urine, one of your body's waste products. The kidneys produce 1.5 to 2 quarts of urine every day by removing waste and water from the blood. The urine travels from the kidneys down 2 narrow tubes called ureters. It is then stored in a balloon-like container called the bladder. In an average adult, the bladder can hold 10 to 20 ounces of urine. When the bladder is about half full, you may begin to feel the need to empty it by urinating. Urine is carried out of the body through the urethra, a tube at the bottom of the bladder. Normal urine contains no bacteria or other germs, but bacteria and other germs do cover your skin and are present in large numbers in the rectal area and in your bowel movements. Bacteria at times get into the urinary tract and may travel up the urethra into the bladder. When this happens, the bacteria cause infection and inflammation of the bladder. In other words, they multiply, cause redness, swelling, and pain. Bladder infection, also called cystitis, is the most common urinary tract infection. If the bacteria travel upward from the bladder through the ureters and reach the kidneys, the person may develop a kidney infection, also known as pyelonephritis. Kidney infections are much less common, but are often more serious than bladder infections.
One problem that the residents may have, especially high-risk residents who are in the end stages of their disease process, is bladder infections, also known as urinary tract infections, UTIs. And the reason why the residents are at such high risk for UTIs, urinary tract infections, is this. Many things. Their oral intake and their fluid intake very well may be lower. They may not be up for eating and drinking as much as they normally would have been. So it's very important that caregivers encourage fluids as much as possible, according to your facility's policy. But increasing fluids in a resident can really help decrease the risk of urinary tract infections. Also, good, scrupulous care after incontinent episodes, keeping the resident very clean. Also, though, if you have a continent resident, it's very important that they get good teaching and be checked to be sure that they are properly keeping themselves clean after they go to the bathroom, after they empty their bladder. Encouraging the resident to empty his or her bladder after meals, before bedtime, to help keep the bladder clear. That can also help decrease the possibility of a UTI. Increasing fluids, increasing emptying of bladder, good peri-care, these are all things that can help decrease the risks of bladder infections in your resident. What will you see in a resident, though, if they do have a bladder infection, a UTI? Some of the more common symptoms the resident will show is they'll have a change of their mentation sometimes. An alert resident might become a little sleepy. A resident with dementia might get irritable. A resident with dementia especially might hold their lower tummy area and not really know what's wrong, but just sort of hold the area. A resident who's alert and oriented might say to you he or she has a discomfort in their tummy lower area. They will also want to use the bathroom frequently. That's called urgency. They feel like they need to go to the bathroom more than they really need to go. And when they do go, frequently they will just urinate little bits. It'll not actually clear their bladder when they do sit on the toilet or when they do have an incontinent episode. The urine might be foul, dark, have quite an odor, and be dark in color. There could be some cloudiness in the urine where you almost see a mucus-looking type of substance in the urine. And your resident might have a low-grade fever. Remember, with the elderly, to have a fever could be 99 degrees. They do not have to have a high fever to call it a fever. Their bodies measure fever just a little bit differently than younger bodies. So if the resident has a low-grade fever, they could have a bladder infection.
Once it is determined that symptoms have been caused by an infection, the physician will prescribe an antibiotic. Antibiotics can kill the bacteria causing the urinary tract infection. The antibiotic prescribed will depend on the type of bacteria found. For simple infections, the resident will be given 3 days of therapy. For more serious infections, the prescription can be for 7 days or longer. It is critical to follow the physician's instructions carefully and completely. Be sure the resident takes the full course of antibiotics even after symptoms improve. This helps to prevent a recurrent and potentially more serious infection.
Residents who are not as active, who are not moving around, who are exposed to colds and flus, have a potential to have fluid buildup in their lungs, and they could get pneumonia.
Pneumonia is inflammation or swelling in the lungs, in which the microscopic air sacs in the lungs fill with pus and other fluids, making it difficult for oxygen to reach the blood. Pneumonia can be caused by bacteria, such as Streptococcus pneumoniae, by viruses, such as some of the common flu viruses, by fungi, chemicals, or the entrance of foreign matter into the lungs, such as during aspiration when food or liquids enter the lungs. Persons who are otherwise healthy often recover quickly when given prompt and appropriate care. However, older adults, such as those with dementia, often develop a very serious infection that requires prompt and aggressive treatment in a hospital. Pneumonia in older adults is a life-threatening condition. Symptoms of pneumonia can vary depending on the cause, but include a high fever, drowsiness, rapid breathing, chills, cough with mucus production, chest pain, and possibly even a blue tint to the lips or under the nails in very severe cases of pneumonia. Residents may also report flu-like symptoms in a viral pneumonia, things like headache, sore throat, loss of appetite, and muscle pain. Again, if you see these signs or symptoms of pneumonia in a resident, seek immediate medical attention. We mustn't overlook the availability of preventative measures for pneumonia. There are vaccines available to prevent 2 of the more common causes of pneumonia. The pneumococcal vaccine prevents the most common cause of bacterial pneumonia, and the annual influenza or flu vaccine that is given throughout the United States every year helps to prevent viral causes of pneumonia. Speak to the resident's physician to ensure the availability of these vaccines for your residents.
Another type of pneumonia your resident is high risk for is aspiration pneumonia. And this is where feeding mealtime is so important to keep a very close eye on the residents as they're eating. A resident who inhales pieces of food could have a buildup of fluids and infection in their lungs called aspiration pneumonia. Vitally important that residents are observed during mealtime, that their diet is appropriate, that the consistency of their food is appropriate.
Aspiration pneumonia is one of the leading causes of death in persons with dementia. To best understand dysphagia and aspiration, we must first understand swallowing. Swallowing is a complex process that moves food and liquids from the mouth to the stomach. Swallowing involves the use of many nerves and muscles in the lips, tongue, mouth, throat, and esophagus, which is the tube that connects your throat to your stomach. Swallowing occurs in 4 stages. The first stage is the oral preparatory stage, in which food is chewed and prepared for swallowing. Next is the oral stage. During this stage, the tongue pushes the food or liquid to the back of the mouth. In the pharyngeal stage, the swallow is triggered and the food or liquid is moved into the pharynx. This is a canal that connects the mouth to the esophagus. Finally is the esophageal stage, in which food or liquid enters the esophagus and is carried into the stomach. Any condition that damages or weakens the muscles and nerves used for swallowing can cause swallowing problems. These conditions could include a stroke or any other injury to the head or spinal cord. Diseases that affect muscles, such as muscular dystrophy. Other brain or nerve disorders, such as Parkinson's disease and multiple sclerosis. Head and neck tumors. Even the side effects of certain medications. And of course, Alzheimer's disease and other dementias can cause a person to develop a swallowing disorder. While the symptoms of dysphagia can vary, here are some common signs and symptoms to look for. Choking on food, liquids, or medications. Coughing during or right after eating and drinking. Wet or gurgly sounding voice during or after eating or drinking. If extra effort is needed to chew and swallow. Pocketing of food on one side of the mouth.
A resident who pockets food, who isn't quite swallowing all their food but keeping food inside their cheeks, that resident has a high risk of an aspiration pneumonia. When the resident goes to lay down and have a rest after he's eaten, be sure his food is cleared out of his mouth, because any resident who has some food in his mouth and lays down is also at a high risk for aspirating it, inhaling that little bits of food in his lungs and having a pneumonia set in from that.
Be sure to monitor your resident for any signs and symptoms of dysphagia. If you see any of these signs or symptoms, report them immediately to your supervisor and follow up with the resident's physician. There are many interventions we can take to help care for a resident that has developed a swallowing problem. The first intervention involves positioning. Be sure the resident sits upright at approximately a 90-degree angle while eating. You may encourage the resident to tilt their head slightly forward while eating, as this helps to aid the swallowing process. Finally, ensure the resident remains sitting or standing upright for at least 15 to 20 minutes after eating a meal. You may also make modifications to the dining environment. The first and most important modification is to minimize distractions in the area where the resident eats. Avoid lots of noise, too many people, too many distractors in the environment that takes their focus away from the task of eating. Because of the person's dementia, it may require extra effort on their part to stay focused on simply bringing the food to their mouth, chewing it, and swallowing it properly. Additionally, avoid doing things that would encourage the resident to talk while they have food in their mouth. Wait until they swallow that bite of food or drink of liquid before engaging them in conversation. Monitor the amount and rate of eating. Encourage the resident to eat slowly. If necessary, cut the resident's food into small pieces for them before sitting down to the meal. You may want to encourage them to swallow 2 to 3 times after each bite or drink. There may be instances in which a modified diet is prescribed for the resident. This can include pureeing foods, serving mechanical soft foods, as well as thickening liquids. Be sure to speak with the resident's physician and/or dietitian regarding these modified diets. Your role in caring for residents with dementia is invaluable. By monitoring for these potential health complications and intervening appropriately, you are performing truly life-saving acts. Much success to you in caring for your residents.